Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit Podcast.
Hey, Jess. Good afternoon, friend.
Hey, good afternoon, Cari. I am very happy to be back in the studio with you. It's just us today, which is going to be super fun. I cannot believe the spring is right around the corner, and I cannot wait for the sun and some longer days.
Me too. I agree. And I'm super excited it's just us today. And I agree. Besides those West Texas dust storms, I always look forward to spring. Today, Jess, you and I are going to give some background information about obesity. We will discuss some of the stigma around obesity, as well as current treatment options.
I'm excited to tackle this topic. It's a large part of any medical practice these days and a difficult topic for patients as well. After, we will segue into our first segment on nutrition series. Today, we'll talk keto. Yes, the ketoacidosis diet that has been a craze for quite some time. What is the keto diet? What might it benefit? What are the downsides of the diet? We'll answer all of those fun questions.
Obesity, a whole body disease affecting roughly 40% of the U.S. population. We're going to talk about what obesity is, what contributes to the disease, and then treatments.
Stay tuned. Once we finish that up, we will clear up the confusion surrounding keto. We are ready to dive into a topic that has been the biggest health crisis in the United States for the last, several decades, and one similar to infertility that preys on people's emotions sometimes. It can be so hard when a patient comes into clinic desperate for an answer to their weight issues. They want to blame it on their thyroid or some other medical reason, but sometimes in the end, the answer is not simple or straightforward. Patients can get lured into spending thousands of dollars on supplements, fad diets, pills, injections, and not see results for obesity. We're going to start with some of the basics. What is obesity? How is it classified? And then we'll go from there. Obesity is defined as an abnormal or excessive fat accumulation that presents a risk to your health. It's classified into categories based on something we call the BMI, body mass index. Yeah. I know, Cari, you and I both talk about body mass index all the time with our patients, but do our patients actually know what that means or what their body mass index is?
Right.
The BMI, it looks at your weight related to your height and calculates a number. So two people are not going to have the same BMI. It takes more than just your weight as a factor. A BMI over 25 is considered overweight, and a BMI over 30 is considered obese. So when you look at that, it's actually BMI of 20 to 24 is normal. You hit 25, that's overweight, all the way up to 29. Then you hit 30, and that's considered that obesity mark. There is a term that we call for 40 and above too. It's a little bit, we didn't make up these terms, called morbid obesity. Right. Nobody come after us for that label there. But it is something you need to know about because you need to be familiar with where you fall in that category. It's not to make a stigma out of it. It's not to make you feel embarrassed, but it's how we can determine where your health risk is.
Yeah, absolutely. I agree. And I feel like people get really scared of that number, I guess you would say. And again, it's supposed to be a marker to give us as physicians, healthcare providers, nutritionists, whoever you're seeing, information on how best to approach things with you and what your risks are. Absolutely. And it's important because 40% of our country's population is diagnosed with obesity. If you're Black or Latino, it's even higher in those populations.
And a lot of times you don't know what your BMI is, you're scared to know, or more often than not, either you're underestimating what it may be and thinking that's normal, because when 40% of the country's population around you has a high BMI, it makes you think, well, you're in the normal range, right? You just saw them at church or at the grocery store or wherever else, and you're like, well, we all look the same. Where we are in West Texas, unfortunately, we have a very, very high obesity rate. And so it makes it so that a lot of my patients are shocked when I talk to them about the numbers and where is a normal versus an abnormal. And it can be hard even on family members. Like when someone's losing weight with diabetes or something, we're trying to get their BMI down, a family member will be like, he looks sickly. He's the only one in our family that looks like this.
Yeah, absolutely.
But there's definitely some medical issues that can predispose or contribute to someone's obesity other than lifestyle. This can include genetics, medical diseases, hormones, certain medications, mood disorders, sleep, stress, and others. You can see why it can be tough to avoid obesity. It is estimated that there are at least 15 genes, which is what we inherit from our parents, that influence obesity. Diseases such as PCOS or thyroid disease do have an impact on this as well. Yes, the poor little thyroid gets blamed for everything. It does have an impact when it is applicable, but it's not always the thyroid's fault.
Yeah, it may not be an end all be all explanation for overweight or obesity, but the function of it can influence it for sure.
Right. And so we'll talk to experts in future shows about both those topics, PCOS and thyroid disease, at tons of length. So you'll feel really comfortable as a listener understanding, okay, if I have those issues, how are they playing a role with obesity as well? But medications, including some antidepressants, some steroids, insulin for diabetes, and others do have an impact. So there's meds that also play a role.
Absolutely. And, the big ones that we talk about a lot, stress and decreased sleep. Getting less than 7 hours a night can cause spikes in certain hormones, such as ghrelin, which controls our body's hunger urges. With 2 kids under the age of 6, I don't think I get 7 hours of sleep any night. So I'm sure my ghrelin level is out of whack for sure. Another hormone playing a big role in obesity is leptin, which is actually produced by fat cells, and it sends signals to your brain when you are full. You can get something we call leptin resistance, and your brain stops responding as it normally would to this hormone. And since it's constantly stimulated by leptin saying, hey, let me in, I'm trying to tell you that you're full, you don't get the sensation of feeling full that you should, which causes you to eat more, even though we've got plenty of energy and we've got plenty of fat stores and we don't necessarily need to be eating anymore. Now, you could ask, why can't we just test for these hormones and fix them and that be the answer for the obesity crisis? Well, those are great questions. Testing on them is not necessarily readily available, and we don't know what to do with a lot of the levels right now because of the evidence that we have. But both of these are huge targets for future research when it comes to the obesity crisis.
Absolutely. It's always been very interesting. Even when we were in med school and they talk about these hormone levels that we've known about forever, it's just like, why can't we just target that and just speed that one up or slow that one down? Well, we're working on it. They truly are. And that's how we've come out with some of these new medications and things that we're focusing on. But if anybody tells you that they have the cure or this medicine or this supplement is going to speed up or slow down one of these hormones, they are not telling you the truth. They want your money. So you've got to be really careful about some of those things because the research does not support the fact that there is a way to adjust some of these hormone levels in your body.
Currently. Hopefully in the future, because those would be great targets.
So now these are the things that we can't always control. Of course, the way that we eat and our physical activity are things we do have more control over. As we've discussed in previous episodes, like with cardiologist Dr. Haley Houston, who was on a previous episode of ours, our diet has much more of an impact on our heart health and how we live our lifestyle.
Yeah, speaking of heart health, why should we care, guys? What negative impact can obesity have on our health?
Well, we mentioned heart disease in a previous episode, like we talked about, which is also tied to our blood pressure, diabetes, or insulin resistance. Trouble breathing or sleep apnea can be affected by this, problems with our joints, cancer. Obesity even affects our digestive tract. Gallbladder disease can be more common with obesity as well as fatty liver disease.
Yeah, and of course, fatty liver and gallbladder disease is something I see a ton of. Which are becoming their own crisis as
so true.
An end complication of obesity. That's kind of a new term that we have all started using is a lot of these diseases are what we call end complications. So, we know the underlying cause is the same for a lot of them, but each of them are kind of having their own issues on people's health.
With fatty liver disease, I have patients that have started off with, we may have seen it on an ultrasound. Maybe we're looking at their gallbladder. We see that their liver looks like it has some fatty deposits in it. Then we start noticing that their liver enzymes start elevating, which goes into a different term called non-alcoholic steatohepatitis. Mm-hmm. Fun words there. But then we start seeing that they have fibrosis of the liver, which is leading to cirrhosis. You have this hardening of the liver. And pretty soon we have a patient with liver failure. And I have patients with liver failure. And I have this one sweet patient that she has told me she wishes she had made different decisions younger in life related to diet, exercise, lifestyle, but particularly the obesity crisis, because now her liver is failing. That's led to so many other complications, and she's relatively young.
Absolutely. And it's crazy because I can tell you, I don't feel like I've been practicing this long, but when I started my training, all we ever talked about when it came to liver disease was like hepatitis C.
Yeah.
Or as all everyone talked about was like Hep C and alcohol. He's like, you could answer that question, like what causes liver disease? You're like Hep C and alcohol. And now we don't see that.
Right.
It's like we've done a great job with curing Hep C. We've done a great job with counseling on alcohol, and now the number one cause that you're going to see is related to metabolic syndrome, diabetes, obesity. That's what's causing liver disease these days.
Which is really scary that that's something that we're not thinking about day in, day out. And we don't, maybe heart health complications might be more on the forefront of thinking about that, but we're not thinking about the liver.
Yeah.
And it happens all the time. I get labs all the time that the liver is abnormal. And I can tell you 99% of the time these days when I do this, it's fatty liver disease.
Yeah. So again, if your doctor is talking about these things, it's not because we like to be mean or judgmental or trying to make people feel bad. It's because we see the end complications or end results of obesity every single day. And it worries us for our patients. And we try to intervene before you get to that point, because unfortunately, some of these diseases don't have a lot of symptoms. So you're not necessarily going to notice anything or worry about it. And that's our job to worry about it.
So if your doctor does say, okay, we're going to use the big O word, sometimes I will say that to my patients. I'm like, we're going to have this conversation. It's going to be uncomfortable, might be hard. Let's talk about BMI. And I talk about them being in the obesity category, because maybe a doctor before them never had the guts to even have that conversation. Yep. And so we'll have it, and it's not meant to be shameful. It's meant to empower you so that you can figure out what you can do to change and get healthier, because we have to practice what we preach as well. I mean, we've talked about this in previous episodes. It's so important. Absolutely. We have to try to set an example.
And, it's not just these physical issues that we've seen. There's a lot of other negative impacts that obesity has. And this includes low self-esteem, higher rates of social isolation. So people withdrawing from social settings or society as a whole. And there's a lot of stigma around obesity. It even leads to bullying in kids, especially with the widespread use of social media. And I really hate how a lot of this discourages people from even trying to get healthier. A lot of the gym shaming when somebody obese or overweight comes in, trying to make these positive impacts, and the negative connotation or negative insults that can be hurled at them. It's just really disheartening, because, all we can do is try. And if you're going to discourage people from trying, then what chance do any of us have? And I have been that person. I've been that person shamed at the gym or trying a new physical activity. So I'm not saying that lightly.
So yes. Okay. So message for our fit listeners who may be using the gym quite often, and they're like, wait, I don't need to know this. Hey, be nice to everybody who's at the gym. Be nice to somebody else, and maybe, offer to help them sometimes if they're struggling to, pick the right weight or something, and they can't get the pin in the machine, or they can't start it right. I mean, when I go to my gym right now, I'm absolutely obsessed with, because it's got a lot of more mature aged people that attend, which is fantastic. Like, nothing makes me happier than being this 9 months pregnant lady walking around, getting up my weights going with these people who are 40 plus years my senior, and they're rocking it. That's awesome. It's really a positive effect when you see that. Now let's transition to interventions. And of course, the type of diet we eat is a huge impact on weight reduction. We will touch on some of this in the second half of the show, but one of the buzz topics regarding weight management and healthy lifestyle is ultra-processed foods. An ultra-processed food is an industrially formulated edible substance extracted from food and can include additives, preservatives, sweeteners, etc. This can include the yummy chips, the carbonated drinks, the ice cream, the cereals, the instant soups, certain lunch meats. But why are these so bad for us? We have studies that connect them to weight gain. Partly this is due to an excess intake of calories that we see with ultra-processed foods. Usually these diets also include more carbohydrates and fats, leading to weight gain. Some of these we've actually been seeing are even linked to carcinogens and cancer risk.
Yeah, absolutely. And you read that list. It's sneaky. It's a sneaky list.
It is sneaky.
It includes a lot of things that a lot of us buy without even thinking about it. So it can be harder than you would think to avoid these things.
And same things for your family. If you're the one that primarily goes to the grocery store, and let's say you're doing okay with your weight, but you have a kiddo with, that his weight is struggling, and we're not trying to shame them, but maybe their pediatrician has talked about childhood obesity, which is on the rise as well. You as the parent are the responsible one for bringing that food home. And so it's a lot of pressure on you to be looking around the grocery store and saying, okay, what I purchase here has an effect on my family. How do I make some of the right choices?
Absolutely. And, when I have this discussion sometimes with patients in clinic and I ask them about how much they eat out, and when the answer is a lot, it's going to be near impossible or extremely hard to impact your weight positively when you eat out a lot, because you have no control over your food. You have no idea what's being put into it, where it's being sourced from. I'm not saying you can't do it ever. I'm not saying you have to go crazy about it. But if you were doing that day in and day out for all of your meals, it's going to be very challenging to try to avoid weight gain or lose weight.
Absolutely.
Some nutritional advice that we do have is to minimize these type of foods, but also address any eating habits such as binge eating or not eating late at night are called night binging. And those have an impact on our ability to maintain a healthy diet. There's also some evidence that small, frequent meals may not be the best option, which some people have touted, because it can cause chronic elevation in insulin, which we discussed earlier impacts our cravings.
That is so true. I can't tell you how many times my patients come in and they say, well, I don't eat that much. I say, okay, we'll start from there. And then they say, well, I only eat one meal a day. Okay, we'll start, well, we keep talking into this, and they're maybe eating one meal a day, but they may be snacking throughout the day. Maybe that one meal a day is consuming, 3,000 calories in a setting. And honestly, you can't eat 3,000 calories of vegetables in a setting. I know that from being a vegetarian for 20 years. You can't do that. So, there's a lot of things that we need to look at, but I can tell you right now, if somebody's been giving you advice that you need to eat these small, frequent meals throughout the day, and you don't have an underlying other medical reason for that, certain things like gastroparesis may do better with that, which is a medical condition that Cari treats all the time. Mm-hmm. They maybe need a certain kind of small, frequent meals, or somebody who has an issue with hypoglycemia, not hyper, not high blood sugar, but hypoglycemia. They may have to have some adjustments in more frequent meals, or maybe in pregnancy or some other reasons there. But for the majority, a 3-meal-a-day structure with 0 snacks is going to be eons more healthy and do you much, much, much better than okay, I'm going to have snacks here, I'm going to skip lunch here, I don't do breakfast type of situation.
Yeah, absolutely. I mean, that's interesting because even showing people that skip breakfast have a higher incidence of weight gain and obesity.
Very true.
I think that's specifically for what you talked about. And I think a lot of it leads to binge eating later in the day.
It does. It does.
For sure. And if you do go back and listen to Dr. Houston's episode, she also talks about some nutritional advice for the heart that really applies here as well.
All very helpful information. And these things are things that I wish I had more time to talk about in clinic, because I feel like this is where we can make the biggest positive impact on someone's health. With physical activity or exercise, it's super important. We just want to try to start with 30 minutes 3 times a week, maybe. That would be about 90 minutes for a week. Go for a walk, a cycle, a swim in the pool, whatever. Sadly, walking around a lot at work is not going to be enough. There have done studies, and it is shown that it's not the same as dedicated exercise. It's good. It's something, get a standing desk, things like that. That's a start. But start slow and increase what you're doing and doing how often. Weight training is also great in women to prevent osteoporosis and retain muscle mass as we age. It also burns a lot of calories. So when we talk about weight loss, I always tell my patients 80% is diet, 20% is exercise. So you really do need to have both components. Now, you can't just exercise all the time and eat what you want. That doesn't work.
Yeah, isn't that the saying you can't overwork a bad diet or something like that?
Yes. No, it's so true, because you can't outrun it, right? You can't outrun a bad diet. It's definitely true. And patients, a lot of times when they come into me and they're very frustrated by what they're doing, they've got one or the other going for them, right? They're either doing pretty good on diet, but they have their calorie expenditure is just not there, right? They have a sedentary job, or they just aren't getting to the gym. And you don't have to do the gym. These are things you can do at home too. A lot of times I talk to my patients and they say, well, I walk my dog every night. So the next question I've learned now is, what kind of dog do you have? Because when you have a little Chihuahua dog and you're walking, you're probably not going the speed you need to be walking. Yeah. I have one that was talking to me all about her Frenchie bulldog and how she walks it. And I was like, no. And then another one that was talking about their golden retriever or their German shepherd. And I was like, okay, you may be going the pace speed.
Yeah. I was about to say, if you're walking my Boston Terrier, you're not going very far. Between the sniff and pee breaks and being a tiny little puppy, you're not getting your heart rate up. 100%.
Yes, exactly. So you've got to get your heart rate up, and don't be afraid to get your heart rate up. If you have an underlying medical condition where your cardiologist or electrophysiologist has told you not to get your heart rate up, that's different. But otherwise, you should be able to get your heart rate up and going. And we're talking some high numbers that you actually may not be super familiar with at first. Your max heart rate is actually a calculation you can do. It's 220 minus your age. And that's your max heart rate that you can get to, especially with exercise and things. That's usually a lot higher than patients think they can get to. Mm-hmm. So try that out, do a little calculation. And so next time you're doing your physical activity, whether it's walking your dog or in the gym, see how close you're getting to that heart rate level. See if you're actually being able to push yourself and try to get yourself a little bit higher. And that way you can burn those calories and have that cardiovascular benefit.
Absolutely. All right. So now with all these habits are very important in weight reduction and overall healthy lifestyle. So we know all that. We've talked about it. But say you're a patient or you have a patient and they're meeting all their nutritional and physical goal activities, but they hit a plateau in their weight loss. What kind of medication options are out there now?
So this is something that happens all day, every day to me in a primary care clinic, right?
Mm-hmm.
I can go blue in the face talking about diet and exercise, and then patients are like, I need an easy button, or I just need something extra to help keep this process going. And there are some patients with some pretty big risk factors who medication is probably a really good idea. Some of them might be in that pre-diabetic stage. Some people might be at those BMIs of 40 plus, where we really have to do something to kind of bring it down so they can even get to the gym. I've had a couple patients who couldn't even exercise at the gym because their legs were rubbing together and creating sores and rashes and ulcerations. And so they can't even get to that point without a little bit of added help. And that's where medications may be a viable option. But there are several to choose from, and it's not as simple as you may think. Weight loss that we see with some of these common medications, just as an overview, Contrave is one. We see about 7% of body fat weight loss. Metformin, 6 to 10% of weight loss. GLP-1s could be up to 20%.
I feel like these GLP-1s are all anyone is talking about these days.
Oh, yeah.
I mean, you can't drive down the street without seeing an advertisement for the skinny shot, the Ozempic, semaglutide, Mounjaro, there's a whole bunch out there. You've heard all the names, and they were actually first released for diabetes management. And I want to focus on these a little bit more. It sounds like the weight loss of these medications, can be amazing, but not necessarily for everyone. Jess, can you tell me more about these meds, their background, and kind of currently how you're using them in your practice?
Yes. So I don't run a weight loss clinic. I run a primary care clinic, family medicine. So I've been using these medications for years. Medications such as Ozempic or Wegovy, semaglutide, Mounjaro or Zepbound, which is tirzepatide. We've been using the medicines in this class for many years. Ozempic and Mounjaro are the originally branded for diabetics, specifically type 2 diabetes. In fact, the whole class of medications called the GLP-1 meds has been revolutionary for diabetic management for several years now. These are not new necessarily, not a new fad to use them for diabetic management. These are mostly formulated as once weekly injections. Yes, there's an oral version of semaglutide as well. That's a side note. We have seen patients who would normally have been started off on huge, high doses of insulin for their diabetes, start one of these instead and completely avoid insulin altogether. So I'm a huge fan of these for diabetes. Now, lately, they have been very popular in the news for other reasons. About 1 to 2 years ago, these medications started to be used off-label for non-diabetics for weight loss purposes. In some patients without diabetes who used medications like semaglutide or tirzepatide, we saw huge weight loss effects in a relatively short period of time. We are talking way better than the previous weight loss drugs available, hence the meteoric rise of the popularity and the fact that every doc in the box is compounding their own versions and selling it at top dollar to patients without a second thought. So how do they work? The GLP-1 medications are, in the most basic terms, they mimic a hormone we talked about earlier, the glucagon-like peptide. And when your blood sugar starts to rise, they stimulate your body to produce more insulin. Insulin helps lower your blood sugar levels. They also slow movement from the stomach to the intestine so you feel fuller longer and you eat less.
Sounds too good to be true, right?
Of course, just like everything, right? GLP-1s are effective, but mostly for people who have excess appetite or who have had obesity long-term due to leptin resistance. We touched on that leptin resistance earlier. They do not work for everyone for weight loss. That's a huge thing to put out there. They don't work for everyone for weight loss. In fact, many diabetics using it do not experience the dramatic weight loss effect that non-diabetics have when using it. So be careful when you're being sold something online or, by a random compounding provider. You've got to be careful. It doesn't work for everybody. So don't put yourself into financial ruin for these skinny shots and things, thinking this is going to be the cure for everything that you're been so frustrated for so long. Insulin levels should be checked prior to starting GLP-1s to ensure this will be effective. Studies have shown that some people with insulin resistance actually lose significant amounts of weight using metformin, which is an old school medicine that we have. And this is comparable to their weight loss on GLP-1s. So we've got to check some labs before just assuming this is going to be the perfect fit for you. If anything is on the spectrum of binge eating disorder, and again, insulin resistance, it needs to be addressed before we start using a GLP-1 because otherwise you may be wasting your time and your money.
Yeah. And aren't there concerns that once you stop the drug that there can be weight regain? I know I've read about that.
Absolutely. And we see this all the time. You actually have to make those lifestyle modifications we've been harping on over and over and over to make these effects long-term. We've seen people lose tremendous amounts of weight and then be so frustrated when they gain all the weight right back quickly.
And the side effects of nausea, vomiting, diarrhea have kept some people from being able to stay on these medications. There are also some black box warnings and contraindications to their use, such as the risk of thyroid tumors in patients if you have a certain family history, specifically a personal or family history of what we call medullary thyroid cancer. You need to talk to your doctor to figure out if this is you. Pancreatitis or inflammation of the pancreas is also a possible complication.
Also, people with lower BMIs using the GLP-1s for weight loss have a greater risk of severe side effects and outcomes. We have seen patients using it with BMIs at 25 or 26, so right in that overweight category, not even obese, who end up in the hospital from it. I've even seen a young patient using it with a normal BMI for weight loss who ended up in the ICU. There are risks to using these medications that oftentimes the telemedicine provider or that doc in the box may not be making you aware of. So they have appropriate use and they can be very beneficial, but you need to know that they are not without risk.
Absolutely. And I've seen these complications for myself and, maybe TMI, but I will say, just because of full transparency, I have tried one of them.
Oh, yeah?
So I did. After I had my second son, I was having some trouble losing weight, doing all the right things. We talked about all that post-pregnancy period and all of that. And I'm not going to lie, side effects, I couldn't do it.
That does happen. And
it was too much. And I just gave up and said, I'm going to have to go back to the basics of what I've done before that worked. But I'll tell you, even I have been sucked in to giving this a try. And I think it was helpful, sure, for the very short amount of time I was able to stay on it. But side effect wise, I just couldn't do it. And so you're right. Maybe in those closer to normal, just overweight BMIs, it may be too much to handle.
And that's a really good point. We need to make sure that we're tailoring a medication regimen to what you need, what you can tolerate, and you don't need to push through just thinking, oh my gosh, if I could just push through, I'm vomiting every day, that I will be able to lose the weight I need to. We need to take care of yourself and be sensitive.
Absolutely. I mean, when you feel that crummy, it wasn't worth it for me.
Oh,
so again, I had to stop it and try something else. But I'll be honest, I did try it just like most people did, it seemed like.
Besides medication, there are other treatment options for obesity, including bariatric surgery. We will discuss this option in a later episode on the podcast with a bariatric surgery specialist, so stay tuned for that later.
This is all such great information and a hugely fascinating and complicated topic. So obviously we are scratching part of it, but it's just, you could run wild on obesity, I feel like.
Absolutely.
Especially with all the new research coming out. Stick around, guys. Next, we're going to switch over to our first nutrition source segment and discuss what is the ketogenic or keto diet.
Okay, we hear a lot about the keto or ketogenic diet out there. It has gained a lot of popularity in recent years, but I find it can be very confusing to some people. Cari, what is the benefit of such a diet and is it for everyone?
Yes, very exciting topic. I agree. People hear this phrase a lot, but don't really know what it means or how it can help them. So I'm kind of glad that we are breaking this down. So, in general, a keto diet is going to be a true keto diet is going to be one where you have a very low carbohydrate, right? So those are breads, cereals, beans, fruits, even some vegetables that have a higher sugar content. And you're going to actually substitute with a high fat content. So that's the kind of key part of a keto diet. This is different some from what paleo, South Beach, Atkins diets, even though a lot of times they get lumped together. And we're going to talk about all of those in more detail in future segments. And the idea is that by increasing fat intake instead of carbohydrates, you cause your body to go into what we call a state of ketosis. And basically it starts utilizing your stored fat as an energy source instead of your food that you're taking in, such as those carbohydrates. On a true keto diet, usually roughly at least 60% of your calories would come from a fat source, maybe 30% from protein and 10% or less from a carbohydrate. Now, I find this overall really fascinating because this type of diet actually dates back originally into about the 1920s, and it still is used in some instances, but was started actually to manage epilepsy. So there was a neurologist or provider who noticed that patients with epilepsy did better on a very high fat diet. Now, what that did for them as far as their other medical risks, I don't know. But this was before they had medications to treat epilepsy. So this was kind of the only treatment option. About the 1970s, it started regaining popularity basically for weight loss in the short term as it was showing effective results short term.
So this is where I get to give my side too. I've definitely done the keto diet for about a year and a half. And then I did a vegetarian version of the keto diet, which probably is a little bit on the healthier side when it comes to it. Because the problem with the keto diet, is there's a lot of differences in what kind of fuel source you're using and how much fat you have in your food choices. So some of the modified keto diets that promote more protein, less saturated fat have become popular in recent years because of some of their health side effects. We need to make sure that we're not just eating bacon. When my patients come in on the keto diet, they're like, I eat bacon every day, and then I eat throw in some butter and some more bacon and some steak. And I'm like, okay, we got to work on this a little bit, right? So the type of foods you will mainly be eating on a true ketogenic diet do include things like butters and coconut oils, obviously meats, fatty seafoods, eggs, mayo, avocado, and cheeses. A lot will allow veggies or fruit if they're low in sugar, like broccoli or blueberries. The modified diets usually promote more options that are lower in saturated fats. The ones we really worry about for heart health, we'd rather do things like lean meats and more fiber.
I agree. And one thing to remember when you start a ketogenic diet, and really anytime you make a big change, but keto specifically, is to keep in mind it takes time for your body to adjust, right? So people actually get something we call keto flu, which I think is really interesting. You can have nausea, vomiting, headaches, fatigue, dizziness, insomnia, and even constipation, which I see quite a bit of. And a lot of that comes from that low fiber in the diet. So, again, you're transitioning to off some of those vegetables and fruits that help you get good bowel movements.
Yeah. So it's not necessarily a be all cure all diet for sure. And a lot of times it doesn't necessarily go long term. So Cari, tell me about that as for long term use of it, what are the health concerns or what have they studied with it?
Right. And in general, again, this is why it's important to talk to your doctor before you make any kind of big diet changes. Because I know you asked me earlier who it was good for, which I'll answer in a minute. But the ketogenic diet for weight loss has been well studied for effectiveness and safety for about 2 years, for up to a 2-year period. Okay. After that, we have limited data. So this is one of those times where we'll tell you after that 2-year period, we just don't know. Some of the concerns about long-term use of the diet include deficiencies in certain minerals and vitamins because you're restricting your diet quite a bit, right? So you're not getting that well-rounded diet that gets a lot of our minerals and vitamins. We talked about constipation too. So that bloating, diarrhea, constipation from a low fiber, high fat diet is a concern. Kidney stones are a concern. We talked about heart disease with saturated fats. You can also get some muscle loss if you're not getting some of that good amount of protein in your diet, right? That's what you need. And maybe even some negative effects on brain function. But again, especially in these last areas, our data is somewhat limited. And I have this discussion with patients diagnosed with fatty liver because this has been one of the instances where a keto diet is not a good choice for you, right? Because it's great for weight loss. We've talked about this short term, but if you have fatty liver and you are doing a low carbohydrate diet that is high in fat, there actually is some evidence this can exacerbate a fatty liver because of the impact on cholesterol levels and thus liver function. So a traditional high fat keto diet, that would not be a good person for it to apply to.
Makes perfect sense.
Now, in general, again, short term, so less than 2 years, if you're doing it correctly, supervised after discussing it with a physician and maybe even seeing a nutritionist, there is evidence that it can lead to weight loss. Absolutely. It's just not something that we have evidence that we can suggest doing it long term as an option for weight loss.
What a great way to start off our Nutrition Source series. We're going to cover all these options, the keto diet, the paleo diet, Atkins, gluten-free, anti-inflammatory. So follow along, you guys.
All right, so we broke down obesity, such an important topic that can overwhelm someone fast. We hope this helps someone out there on their journey to a healthier lifestyle.
We hope we have edited out the misconceptions surrounding the keto diet as well. Like this episode, subscribe, turn on notifications for new episodes, tell your friends, and stay tuned.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when new episodes become available. For more information about this episode, and to learn how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. And don't forget, click that follow button to be notified when new episodes become available. The information and content has been made available for informational and educational purposes only, and does not constitute a physician-patient relationship. If you need medical advice or help, contact your personal physician. The views and opinions of the guests do not necessarily represent the views or opinions of Dr. Jessica Gray and Dr. Cari Sorrell. This podcast should not be considered as an alternative for medical advice, diagnosis, or confirmation of an illness or disease. Please seek assistance from your personal health practitioner.